been too long in this profession. Maybe it's not very well known to you, but we'll give you a little orientation now. This is the TUR syndrome, a clear but rare complication. I'm from halfway up to the North Pole, from this lovely summer city, Stockholm. And we're going to talk about this complication, which really can occur in several operations, but most widely described in the TRP and the TCRE settings. But it can occur actually in all these ones, and it has been described. It's associated with use of irrigating solutions, which is used in genitourinary surgery for technical reasons. They're not of very much interest to us anesthetists and intensivists until they become absorbed by the body, which can occur occasionally through severe prostatic veins or through instrumental perforations in the operating field. We have two types of surgeries to talk to, or two types of electrocutting. And we'll discuss them both because they differ a bit with regard to this complication. Now first we'll take the original one, which is the monopolar resection, where electricity, the cutting thing, goes from the tip of the resectoscope here, that's in the area of the prostate, and it goes down to the back of the patient. If you have this kind of setup, you must have an irrigating solution that is electrolyte-free. And electrolyte-free solutions are on the market, and I'm sure that you know them. They have somewhat different features and characteristics, and a little difference also in complication incidence, but we will not go into that. We'll dig back into history and take some of the history of this complication. It was originated with the TRP operation in the 1930s, when actually they used sterile water for irrigation. But as soon as it was noted that it could be absorbed by the patient, the urologist noted that hemolysis occurred and the kidneys could be harmed by this. So there came a trend to add non-electrolyte solutes to the irrigating solution. Maybe not to make them isosmotic, but to make them non-hemolytic. And then it was continued for some time. We thought that the problem was solved, but it was not. So it appeared later in the 1950s that absorption of 3 liters of fluid or more really could cause this complication. And then, of course, we added knowledge with time that this was associated with hyponatremia, which was not strange, as the irrigating solutions were non-osmotic, didn't contain any sodium at all. So it became what we thought at the time was dilution of hyponatremia. And details about dose dependency appeared much later. So it is not a yes or no complication. It looks like this, that as soon as you absorb more than 1 liter of irrigating solution, at least of glycine, which is in this case, and you have a statistically increased incidence of symptoms, and if you absorb more than 3 liters, you have a full-fledged TUR syndrome. And the symptoms really can look in very many different ways. This is one of the publications I did many years ago. Most common ones are nausea and arterial hypertension appearing in the postoperative care unit, about 30 minutes after the operation. If they occur during the actual operation, you have a pretty large absorption. But we'll not discuss this very much, just to let me conclude from many studies of infusing this in volunteers, animals, and cell cultures and so on, that glycine 1% has the highest incidence of complications of the irrigating fluids that are on the market. So in my opinion, it should be taken away. You can monitor this irrigating fluid absorption with ethanol as one method. You don't have to take it in retrospect by measuring serum sodium. You can have it directly through using an irrigating fluid that contains 1% of alcohol. That gives you an early detection. But I won't talk much about this. I would like to focus on what you must know as an intensivist and what kills patients, because this can really be dangerous. And I would like to focus on just a few topics that has with this to do. There are 2 issues that are serious here. The first one is hypoosmolality. Now, most irrigating solutions like glycine 1% and NaCl 3% are actually hypoosmotic, and osmolality around 200 millimoles per liter. And in these experiments here that we did on the pigs, we surely had a reduction of the of the serum osmolality, which was reflected by an increase of the intracerebral pressure. So it really went up here, it remained high. For good, now, if you have this complication, you know from many case reports that it does take some time for this to occur. So you do have, if you understand the complication, you have a couple of hours to do something about it and to prevent death from occurring. The second issue is more problematic directly, and that is a hemodynamic shock. That occurs very much in association with the absorption event. Actually, when it starts when you have ended the operation, and sometimes on the operating table. These are the animal experience once more. You can see that we infuse glycine here in a volume that's about to an adult, being 4 liters. Calculated back the pig here, or 20 kilos. You see that cardiac output goes down all the time, down to very low levels, although we have a hypovolemic condition. Is this hypovolemia or hypovolemia? That's been a question historically. And of course you would believe this is hypovolemia. But I have a couple of experimental studies and data that show this is really hypovolemia. And I will soon explain to you why this is hypovolemia. I've studied these pigs with a kinetic model. And what happens if we absorb fluid here into the plasma here, it expands the plasma, and it exchanges fluid with the interstitial fluid, and we have uptake to the cells here. We can see that what happens if we infuse irrigating fluid here is that we have a profound osmotic diuresis. So the animal loses sodium, ions, and it loses water through a profuse renal excretion here. As the fluid is hypoosmotic and it also loses sodium, the uptake of fluid to the cells will be very large. So the transfer of fluid from this part, from the plasma to the interstitium, is not coupled with the backflow. There's no flow back. So what is lost to the interstitium stays there, doesn't come back. This is a phenomenon that I only seen kinetically actually in the past, only in septic patients it can occur. So whatever, if we use this model and kinetically simulate what happens if we infuse irrigating fluid at different rates here, as they always end up with hypovolemia afterwards. And that is, let's summarize now what I actually told you about. It induces vigorous osmotic diuresis, losses of fluid and sodium. This causes uptake of volume to the cells, which even makes worse with sorbitol and glycine, as these solutes are also taken up by the cells, although at a little slower rate. So there are several reasons to why we have cellular edema, and there's no return backflow. So the patient becomes hypovolemic. That means that if we treat these cases, we should, of course, first take care of the patient's general condition, then expand the plasma volume by preferably a colloid. And vasoactive drugs to maintain tissue perfusion. We should infuse hypertonic saline, that's to take back the fluid from the cells, and you don't have to worry about giving this very slowly. You should try to speed it up a bit. Because there's no reason for being cautious here. Diuretics at the end. When you have the situation under control, you can say diuretics then, not begin with that, which is all told in many textbooks, because that makes the hemodynamic situation worse. Okay, what happens also is that the tissues become damaged by a large overload of irrigating solution, like we hear inflammation in the heart by glycine. This is breakup of cardiac fibers, also by irrigating fluid. This is damage of the site architecture, that's from saline actually. So this is not only from irrigating fluid, also from saline. And here's a normal tissue, but this is after overhydration. So that causes some degree of organ dysfunction. And this has been created in the period of glycine. It makes the worst changes, and mannitol is the best one. Not saline is not the best solution to give actually in overload. Okay, that's for the bipolar. I will say a few words about the bipolar TURP. That's a more modern type of electrocutting. Then we don't have the electricity going through the patient. It's only generated here at the tip of the receptoscope, and that means that we can irrigate with saline. which is of course much better because the electrolyte solutions are less dangerous than the non-electrolyte solutions. However, there are some problems with overload with saline too, and the rates of absorption here can be very, very high. About 2.5 liters per 10 minutes or something like that. So that's a problem. But for good, cerebral edema will not develop. Very little is published about this, right? The scientific interest in the TR syndrome has decreased quite much. We have some incidence studies that show that absorption incidence is almost like it was before, between 2 and 10% of the patients undergoing TRP absorb 1 liter or more. But the symptoms are less dramatic, and of course serum sodium cannot be used to assess the absorption. But the other problems, cardiac damage will probably remain, and the tissue injuries will still remain. But very little is done about this, so I can't tell more. It's only about 10 studies of this bipolar resection adverse effects being published so far. So it's very, very little. But I would like to remember you must distinguish between bipolar and monopolar surgery, and you must know the treatment of the monopolar fluid overload because that can kill patients. This is the bipolar situation is just a regular fluid overload, and I think that many of these mild cases may go unnoticed as there is very difficult to detect this fluid absorption. Glycine should be abandoned, mannitol is much better. So, some conclusions about bipolar. It will change the characteristics of the TR syndrome. Pulmonary edema will probably more, we'll see more that. And of course, we will have acidosis with this irrigating fluid saline, but we will also have this with the electrolyte-free irrigating fluids, of course, as they don't contain any electrolytes either. That was for me. Thank you.